So in this segment, I just want to take you on a brief guided tour through my EMDR pain protocol, page by page, step by step, to help you really make it work for you, to know what you really must have, what you can dispense with, and what to do at some of the different decision points along the way when desensitization, reprocessing isn't happening successfully, and so on. So to begin with, of course you introduce the EMDR pain protocol when you've decided that the client is ready to participate in desensitization and has the goal of alleviating pain or trauma after you've thoroughly assessed them and, as far as possible, made sure that there are no other major problems or current stresses that might be impacting upon their ability to engage in desensitization and reprocessing safely and productively. Now, of course, it's going to happen that you'll start EMDR processing and find out that there's other things going on, and that's part of the therapeutic process. You do the best you can with the information that you've got. I do want to say at the outset that the protocol is not, in my opinion, therapy. It's a structure designed to hold and facilitate therapy. You can do good EMDR without necessarily ticking every box in the protocol, as long as you understand why the protocol was created, which is to make sure that you have the client on the tracks, meaning they're engaged emotionally and sensorially with the problem in a contained way and simultaneously able to attend to the bilateral stimulation and derive benefit from that and notice the effects of that and integrate them. When I first started working with the EMDR, I'd never really defined or thought to define problems in terms of those three prongs of thought, sensation, and feeling. I'd talked a lot because of my original CB training about thoughts and feelings. I'd never really introduced that element of the bodily sensations and the affect, and that really seems so obvious once you start doing it. And I wondered how I'd ever done any sort of good therapy without it, and perhaps I hadn't. But anyway, that's really one of the great things about EMDR. It just helps you to work better with your clients, presenting problems and the way they're experiencing them in terms of those mind-body dimensions. So of course, before you go ahead you want to implement the EMDR pain protocol or any protocol, you want to make sure that you have a source of bilateral stimulation, and in this case I recommend audio BLS and some headphones ready. In terms of the pain and the adaptive information processing model and how you present that to the client, the main thing is just to convey the idea that pain can become chronic as a result of experiencing pain for too long, or as a result of chronic stress or trauma, but that our nervous systems can heal, and EMDR creates the conditions where that happens. I also often mention to clients that research that I mentioned earlier in the workshop about the research involving the squid who they had induced chronic pain in, and it was found that those squid with chronic pain were better able at surviving threat from predators. And kind of reframing chronic pain as something that may have started out as something adaptive, part of the person's stress response as a way of dealing with threat, and it's just become, if you pardon the colloquialism, overcooked, and the person's nervous system is just overreacting to things, and pain and stress have become hardwired in. Also, when introducing EMDR and the adaptive information processing model, don't overpromise. It's just best to introduce the method and the possibilities and let the therapy speak for itself. So now, getting to the targeting, you've got two choices really, depending on whether the pain is post-traumatic pain or whether it's non-traumatic pain, which is usually medical or functional pain. If the pain is post-traumatic in a very direct way, such as whiplash pain or perhaps vaginal pain in a female survivor of sexual abuse, then you really set up the target pretty well the same as you would if you were treating trauma, except that the pain may be substituted for the emotion, although likely as not the client will want to work with the emotion, as you'll have seen in some of the case studies I presented. Now, with non-traumatic pain, you're usually targeting the pain itself. So there is no image in the sense that there's no memory that's related to the onset of the pain. So you create the image by getting the client to describe their pain in terms of its size, shape, temperature, and so on, and then asking them what that reminds them of, or what it's like, or if they can get an image of their pain based on that description. So you build an image basically out of the client's description of their sensory experience of their pain. Or you can get them, and there are various ways you can do that. You can get them to draw a picture, and so on. But once the client's on the track, and you can see that by the fact that they're engaged, they're not too overstimulated, they're focused, they're calm, and they're present, then you don't need to keep getting them to describe their pain or more information. Once they're on the tracks, you move on to the next phase of the desensitization, which is, just to finish that off. So the aim of that first phase of the target is to get a sensory-based mental representation of the pain. Negative cognition. Now, we've talked about the different themes that you can have for that. They can be trauma-related themes such as safety and vulnerability or control power, or more pain and injury-related themes to do with responsibility and feeling defective. As long as the client gives you a self-related belief, it doesn't really matter what category of negative cognition they give you. It'll all work. Positive cognition and VOC. Clients can find this quite hard even when working with trauma-related targets, and it's even harder when working with chronic pain for clients to even come close to being able to imagine that they can control this discomfort that has often plagued them for years. So unless you can obtain something fairly readily, I find it's just quite okay to dispense with the positive cognition and the VOC and backload it at the end of desensitization reprocessing, when the client's feeling more comfortable in their body and they've experienced some sort of capacity to control their pain and feel better. You can just spend an awful lot of time here on that, and it interrupts the flow, and it's not going to stop you doing your therapy if you haven't got it at that point. Okay, moving on to the emotion, the subjective units of distress, and the sensation. If you're targeting traumatic pain, you can choose between the emotion or the pain sensations rather than necessarily having to obtain both. Again, the more bits and pieces and steps you have, the more it just breaks up the flow, the more likely the client is to go off the tracks in this work. If you're targeting medical pain, you can substitute the pain, the discomfort, for the emotion. You don't have to get both. It's just adding another unnecessary layer. And the reason that I separate sensation and emotion when treating pain is that while emotional distress is clearly an exacerbating and intrinsic part of the pain experience, it's not necessarily a primary component of the target, the way that it is when you're working with post-traumatic memories and targets. And the SUDs, the subjective units of distress, can be used to rate the pain or the emotional distress, whichever one of those two you're deciding to work with. So the location. This is usually known from the history-taking process, or would have come out in the client's description of their pain by now. So again, it's something that happens in the flow of therapy rather than necessarily having to be obtained in this ABC kind of fashion, where you're following the protocol. But of course, if you get to this point and you haven't obtained the location, it's probably relevant information, because it relates to the site of injury, and it'll be an area of the body where the client is most guarded or tense or affected in their ability to function and affecting the general sense of themselves. If there are multiple sites, ask the client if there's one that stands out that they'd like to work on first. If they sort of seem all much of a muchness, then just instruct the client to notice those multiple sites, however they notice them. The processing will still work. You don't have to have one perfect target, right? Okay, so now we're ready for desensitization. So, as I've mentioned before, I prefer continuous audio bilateral stimulation, where you're checking in without ceasing bilateral stimulation. You're using sensory focus to a much higher degree than you might be used to doing when you're working with traumatic targets. You're closely tracking physical responses. So asking the client questions like, not just what do you notice now, but what does it feel like is happening in your body? And you're not just relying on the client's ability to notice and report changes, but you're also taking an active role in helping the client, facilitating their ability to notice those changes. So questions like, do you notice anything different about how you feel in your body? Has the pain shifted or moved? Is there anything else you notice going on in your body? Sometimes just feelings of relaxation. It's a dance. And I mean by a dance, I mean between you and the client and their ability to notice the physical changes following bilateral stimulation. So you're opening the dance with bilateral stimulation. But from the first check-in, if the client doesn't lead with positive changes, then you have to lead by directing their attention to their present felt awareness and looking for those micro changes in experience, or just giving them more time with the bilateral stimulation. Okay, that's fine, just keep going. If the client reports nothing, no change or no difference after their first set of BLS, it's nothing to worry about. They might just need a bit more time, and quite often that's the case. Once the client is able to notice something positive, then you drop back and let them take the lead and you follow. So you're kind of leading from behind. And so it goes. You're also not just doing EMDR. There's many points in the middle of the EMDR processing where things come to a halt or it's not happening, where you've got to go out of EMDR and into adjunctive therapies or other issues, or rechecking your case conceptualization. It's not a linear process as per the EMDR pain flow chart, where you're just processing a trauma ABCD, from start to finish. It's much more convoluted as per the EMDR pain flow chart, with other issues, other modalities, dealing with blockages, and so on. Next, incomplete processing. So, first of all, don't keep doing bilateral stimulation if nothing is happening after a few check-ins and after several minutes of continuous audio bilateral stimulation. Remember that pain is often part of other interlocking problems, and again, you'll often need to be willing and able to jump in and out of EMDR with other treatment modalities, interventions, and treatment focus. It's really like juggling multiple balls. And those multiple balls can be trauma processing, emotional regulation, existential issues, self-care. It's a very dynamic and complex process. Okay, coming on to antidote imagery. So this is for clients who need help with ongoing pain, which is the majority of clients, unless you are working with clients with simple post-traumatic pain. So with antidote imagery, you've basically got two choices. You can develop an antidote imagery out of the physical changes that the client reports following bilateral stimulation, which is by far my favorite form of antidote imagery because it's grounded in the client's own experience and you're using their own associations and memories to build it. So it's going to be the most real of anything. The other possibility, if you aren't able to do that, is to ask the client to think of something that could take the pain away or make it better. And that's an appeal to their subconscious rather than their subconscious mind. Rather than the conscious mind. So the conscious mind will say something like, a drug or an injection, and that's not going to work because it's not a client-centered resource. But often the imagination, the subconscious, will come up with things like wet towels and blocks of ice and pools of water, and those are sorts of things that have more of a sensory, evocative reality to the client that are more likely to impact their pain. And you install that by pairing it with bilateral stimulation and instructing the client to process it in between sessions. The body scan is, of course, checking in with the client following desensitization to check what's happening in their body and helping them to detect and report on any changes. In fact, I do the body scan with whatever interventions I'm doing, not just EMDR, to help ground the client in the treatment that I'm doing. And whatever I'm doing, I'm trying to ground it in the client's sensory experience. I think that talking and insight is important, but I don't think that much change happens that way. I agree with Bessel van der Kolk in that department. At the same token, you don't want to overdo the body scan, because if the client is experiencing high levels of discomfort, then you're just, giving them an unpleasant experience, really. So you need to use it judiciously and as a way of facilitating beneficial processing and progress. So I hope you kind of understand that. Having said that, and also with the body scan, whereas with trauma work you might be looking for a zero or complete cessation of discomfort, and chronic pain, that's rare. You might get significant improvement or relief, but it's pretty, I'd say, normal really, for clients to have some residual pain. But quite often that residual pain is something they're accepting of and are able to live with, compared with what they had when they came into you and first started seeing you for pain management. Closure can involve accepting, incomplete processing, that there's some ongoing pain, and that the client has a better quality of life, that pain is less center stage in their life, that they're engaging with life in a more active way, they're less afraid of the pain. They've got a sort of a post-pain sense of self. And just finally, to finish, the protocol is there to guide you if you feel unsure and to help you in the early stages when you're learning. But I encourage you, as you develop more experience, not to put it in front of being present to your client and their experience too much. I remember when I started doing EMDR, it felt very awkward, and I felt really like I was just back to school as a therapist. But as I came to understand what the purpose of it was and what I needed from my clients for EMDR to work, I was happier to go along with the flow of the process of therapy. And I certainly don't, I have a protocol in my head now, and I'm making those decision points really based on what's happening with my clients. It's very intuitive and it's very smooth and very quick. So I hope the protocol will help you to get established, but I encourage you to use it judiciously with your clients and their experience, and to use it to support a flowing client-based experience rather than one that's too mechanical or by the book. So thanks for your interest, and I wish you all the best with your work.